Thank you all for joining us today for our webinar, Addressing Adolescent Substance Use via Telehealth. My name is Jessica Samuel, and I'm the Finance and Program Associate at IRETA, and I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar via two methods. If you have questions for our presenter or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Jim Winkle, is going to answer questions throughout the presentation and also save time at the end. So please feel free to submit questions at any time, and we will relay them to him. Again, you can submit questions throughout the webinar using the chat function or the Q&A panel. This webinar has been approved for 1 PCB and NADAC credit, which are free, and you can also request a general certificate of attendance at no charge. Please take note that it will take up to 48 hours for your CEUs to be available. Our systems has to cross-check and verify your attendance on the webinar. After the webinar, you'll receive several follow-up emails. The first will be an email with a link to the evaluation, and the second will have information on how to access your certificate of attendance or continuing education credits through your MyIRETA account. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenter, Jim Winkle. Jim has trained hundreds of providers and behavioral health specialists on how to address substance use with patients. As the creator of the Expert Oregon website, Jim has designed screening forms, clinic tools, and training videos used by health professionals across the country. He currently works as a consultant, delivering training and technical assistance on how to address substance use and intimate partner violence, as well as perform motivational interviewing in medical settings. Okay, Jim, if you're ready, I'll hand things over to you.
Great. Thank you. Good morning, everyone, or good afternoon. It's morning here in Bend, Oregon. And you should see my slides right now. And I'm going to go to slideshow mode here. Okay, so we should be good to go. You should see my first slide here. Thank you for taking an hour out of your time today to hopefully learn a few things about how to effectively address substance use with adolescents in virtual settings or via telehealth. Just a note here, I don't pretend to be the expert or the only expert on this subject. I'm sure a lot of people, a lot of participants in the audience have done this and may have some tips of their own or maybe some struggles of their own too to share. So maybe we can learn together through the chat function. And of course, like mentioned earlier, if you have questions during the presentation, feel free to put them in the chat, and I will save 5 or 10 minutes at the end for questions and comments. So let's get started here. I have nothing to disclose financially.
Jim, I'm sorry. Really quickly, we're seeing your presenter view of your slides right now, so they're not full screen. Is it possible for you to flip the screens there?
Let's see. Share my screen, screen 1. How about that?
Let's see. Nope, that's the same way. We can see your notes on the side there.
Okay, so let's try screen 2.
Perfect. Yep.
You.
All right. Sorry.
Let's fit. And let's see if I go forward here. Okay, so today we're going to talk about the functions on a platform that are helpful when we're trying to engage adolescents, how to connect with adolescents, and also how to encourage privacy. Because obviously when we talk about substance use, like other things, when we talk with adolescents, we can provide better care. We connect better when we know privacy is more or less ensured. And how to screen. Hopefully when we screen for substance use, we use validated tools. And there's some tips on a telehealth visit that make sharing those screening tools more effective, I think, when we need to screen for substance use. And then finally, when we intervene, which is essentially a conversation or a brief intervention with an adolescent, and when we talk about this, we're going to talk about 4 steps, a concrete model to use to do this, and again, how this can be tailored in a virtual setting. So those are the objectives. And just a note here, pretty much all that I talk about can be referenced later on the Esprit Oregon website. This is a site that I manage. So the screening form that we're going to look at today, there's some demonstration videos. And by the way, in a couple of weeks, we'll have some new videos that will actually show telehealth settings with adolescents. Clinic tools, slides, and even a screening app, which works well. So espritorgan.org. So what is our current context? With the pandemic in adolescence, basically it means for adolescents that they are experiencing isolation at home, they're experiencing school virtually, and if they do see their peers, they're supposed to be distant from them. And those 3 things probably impact their emotional development, unfortunately, because this has gone on for a year now, will go on probably longer. So we know that how we develop our social skills as a teenager, how we develop empathy and a sense of identity, these are all things primarily done through interaction with peers. This is how we grow emotionally, and this is how we develop these skills. So suddenly that was taken away a year ago, pretty much. So that's likely to impact or kind of stunt the growth of some of these skills. We know when we become adults later that our self-esteem is tied or correlated to close friendships we form as adolescents earlier. We're better able to manage mental illness or mental disorders like anxiety and depression as adults if we had close friendships as adolescents. So unfortunately, this is another way the pandemic may be impacting the future emotional health of our teenagers. If there are supportive adults that teenagers are used to being in touch with or in contact with before the pandemic, they may be a lot less accessible now. And then the other important developmental piece when you're an adolescent is you start to separate from your parents. It's an important skill. So you can spend time with your peers and develop a sense of identity. And of course, that's harder to do during the pandemic if we are stuck at home, sheltered at home with our family. So basically, these are the main things that emotionally are probably impacting our youth. This is a survey I wanted to share because it asks young people themselves, and this was in June last year, so in the middle of the pandemic, how are you feeling, basically? And as you can see, there are about a third more adolescents statistically who feel unhappy or depressed after the pandemic started than before the pandemic. About a quarter of them do not feel connected at all to school adults or classmates. So that's probably partly a result of being isolated at home. And about a third are much more concerned than usual about having their basic needs met. So a lot of stress going on at home for many adolescents. Unemployment, sickness, stress. So again, the adolescents report that they are feeling the impacts. And I just want to have 2 or 3 slides here about assessing for suicide. Obviously, that's a whole separate training, and I recommend that if you haven't been trained in how to assess for suicide risk with adolescents, that you should take advantage of that. But because if you are in a virtual setting with an adolescent, if you're talking about a sore throat or substance use or whatever visit it is, keep an eye out or an ear out for signs that you should screen for suicide risk, because you don't have to be a trained professional to do this. Friends can do it. Any adult can do it. So whenever you're in a telehealth visit with an adolescent, if you hear signs that the patient discloses to you that they just seem very hopeless, they've experienced loss, like a family member or a friend, they just feel like they can't bear the pain, the emotional pain. They don't talk about the future, or they talk about the future in a way that they don't seem to have one. They're giving things away. These are all things that should trigger you to think about assessing for suicide risk. And that's important because when we screen for suicide risk, we're not enhancing the risk of suicide. Anyone can do it. And a common tool that I recommend, that everyone recommends to use, comes from Columbia University. You may have heard of it, the Columbia Suicide Screening Tool. Again, this is just 6 questions, and it may be part of your a clinic process, even a virtual setting, that you hand this off or schedule with a behavioral health specialist or whatever this is, or maybe you are a mental health professional. But anyone, again, can screen for suicide risk. And as you can see here, the questions correlate with 3 different colors. And based on those colors, you can see it stratifies risk based on method, plan, or intent. And then you can respond appropriately. And this may not be your role to respond with a safety plan, and maybe someone else, but again, anyone can actually screen for suicide risk. So I just wanted to mention that here during this training, because this is really important when we visit with adolescents in virtual settings. Okay, back to substance use. So what are the possible negative impacts? Probably not a surprise here. A teenager who's isolated at home or cut off from their peers, it's very likely we're going to see across the population increased rates of depression, anxiety, boredom. Well, those are all things associated, unfortunately, with substance use. Again, stress at home, that maybe their parents have lost a job, or maybe someone's sick. So a way to escape feelings of stress at home, unfortunately, could be through substances, could be through marijuana or alcohol. You know, teens, some of them are still socializing in person. Maybe they're sneaking out and doing it, or maybe you know, their family just can't keep track of them. There are teens still seeing each other in person. That is a risk too during the pandemic, not just for catching the virus, but for substance use, because if teens do hang out together during this time, you know, a lot of things are closed. The movie theaters, underage coffee shops, maybe skate parks. You know, things where teenagers usually socialize may be closed. So that might encourage, again, well, using substances together as a recreational activity or a way to socialize. So it's another risk. And then if for teens who are already in substance use treatment before the pandemic, and now they're isolated, being locked down may trigger a relapse. It's another possible risk. And also, they may have been seeing someone in person, maybe through a peer support group or a one-on-one counselor as part of their treatment. Well, now maybe they can't do that. They have to do it virtually. That may be less helpful. We don't know yet for those who are newly diagnosed with a substance use disorder compared to seeing someone in person. So they may be at greater risk again for relapse. So these are all some of the possible negative impacts. However, there may be some possible positive impacts. For example, if a teenager is stuck at home, in addition to the drawbacks of that, it probably means there's less opportunity to obtain substances, right? So there could be decreased use. If they're not seeing their friends, well, some of their friends who do use, if they have less access to them, that is a strong risk factor for adolescent substance use. If you have exposure to peers who do use, maybe they have less access to them. For some students, you know, going to school in person isn't great. It's very, it produces anxiety. Being around people for some teenagers produces social anxiety. So it could be that remote learning at home could be reducing some of that stress. Some teenagers do better, actually. Sleep is a really important thing when your brain is growing and you're a teenager. It's possible during the pandemic that you're probably getting more sleep. It's possible that that helps because you're not having to show up at school and commute to school at an early time. So maybe teenagers are getting more sleep. And then for those teenagers, again, with substance use disorders, one benefit, in addition to the drawbacks, is probably accessing treatment virtually has expanded because, like everyone almost who provides services to adolescents, they kind of have to do this virtually now. So it's possible your options have expanded. So positive and negative impacts of the pandemic on teenagers. So how about the data? You know, we're just theorizing here what's going on. Do we actually know what's going on with adolescent substance use? There's basically 2 studies. There is one in the States by the CDC that measured frequency of substance use before and after the pandemic, but unfortunately it was 18 years older and above were their survey subjects. It did show that across all age groups above 18, substance use did increase. Perhaps we can extrapolate that also means teenagers. But there's also this Canadian study, and it's a good one. It's a lot of teens. It's in the age group that we're looking at. And as you can see, when they compared before the pandemic to after the pandemic started, actually use among teenagers decreased. So across the whole population, numbers decreased. Now that's specifically binge drinking, using cannabis or vaping cannabis or tobacco. Basic alcohol use, non-binging alcohol use did not change. So that's good news. However, the bad news is for those teenagers who were using before the pandemic, their use did increase after the pandemic. So if we look at that subset population, their use did increase. And then the survey went on to see, well, what was the setting in which teenagers used? And as you can see, about half of them used alone. About a third of them used with peers via technology. So probably on their phone with social media. And then surprisingly, again, a significant number of teenagers are meeting with their peers in person. So about a fifth of them or fourth of them are using substances still in the pandemic with peers. Again, this is a Canadian study. It's the best we got right now. I'm sure more data will come out in the next few months. So substance use is going on. And when we say substance use rates before the pandemic and after, well, what were they before the pandemic? Well, every 2 years or so, SAMHSA does a big survey. And as you can see here, this is what the latest data we have. This will be updated soon, I'm sure. Stratified into 3 age groups. You can see the alcohol, marijuana, and tobacco use, and these are percents. And this is use in the past year. So sometimes we do surveys past month, but this is past year. And obviously, as you can see, the older you are as an adolescent, the more likely you have used one of these substances in the last year. So alcohol is the most popular, followed by marijuana and tobacco. Really, these 3 categories of substances make up the bulk of adolescent substance use. Probably after these 3 is abuse of prescription pain meds or maybe abuse of Adderall, but the numbers go significantly down for those categories. It's really alcohol, marijuana, and tobacco is what we focus on with adolescents. And then I put this timeline in here because several states have legalized cannabis. People are worried of how that might impact adolescent use. So far, you know, the numbers have gotten pretty stable. For 12 to 17-year-olds, it's that bottom yellow line there. So over the past 16 years, or at least from 2002 to 2018, adolescent substance use, at least for cannabis, has not gone up that much. It's stayed pretty steady. Then the other drugs, again, this goes down to less than 5% of teenagers who've used this, and even less than that if you're under the age of 16. Still is out there. We should still screen for this. That's part of our process, but a lot less of this kind of use going on compared to alcohol, cannabis, and tobacco. And if you're a health professional, and I'm kind of presenting this, by the way, I'm kind of assuming this is going to be in a medical setting, but this presentation does apply to a mental health setting as well. But if you're a health professional, you probably are already aware of the risks. You know, why do we screen adolescents for substance use? Well, one of the reasons is there's a lot of morbidity tied to it, especially with alcohol in particular. Teenagers' brains are at a sensitive stage in development where they're more sensitive to the impacts of alcohol than an adult brain. They are even more likely to make poor decisions than an adult if they're affected by a substance. So things like STDs and pregnancy can go up, assaults, not doing well in school. If you have a genetic predisposition to a psychiatric disorder, alcohol and cannabis can increase that risk. And then, as we'll see in a slide later, the younger you are when you begin using a substance or initiating use of a substance, the greater your chance later in life of becoming addicted to that substance. So adolescence really is the key phase of life when we should be addressing substance use, because we can really prevent not only these things from happening in their immediate lives, but also things happening later in life. So that's alcohol. This is cannabis. Less hard evidence here, but pretty good evidence that we know, especially heavy. So this is heavy cannabis use. What's heavy cannabis use? We don't know yet. The problem with a substance that's been criminalized for so long is that we have a lack of research. We have a lack of what a standardized dose is, how many doses is correlated with what morbidity. But in general, as an adolescent, if you use heavy, these are things more likely to happen, right? Your brain isn't going to work as well. There's a chance of addiction. About 1 in 6 teenagers who use cannabis frequently become addicted. And again, a chance later on in life to become addicted as an adult. More likely to get in trouble with the law, car accidents, etc. So these are all reasons why we screen for substance use. We're coming at it from a health perspective as opposed to a judgmental one. You know, if you're a health professional, this is what you do. You screen and you have discussions with patients about risks to their health. So this is a slide I mentioned earlier that for alcohol and marijuana, the younger you are when you initiate use, the greater your chances later as an adult or over the course of your lifetime is you will become dependent on that substance. Dependence is a term we used in the DSM-4. Now we say substance use disorder, but when this study was done, we say dependence. So as you can see, those numbers go down the older you get when you begin using. And there is some evidence that a few words of positive reinforcement from a health professional to an adolescent who has not yet initiated use of a substance can further delay initiation of that substance. So unlike adults, if a young adolescent does not report any use of a substance on a screening tool, you should still respond. And in that case with words of positive reinforcement. Now, it looks like here on your screening tool that you haven't used alcohol, you haven't used cannabis. You know, I'm glad to hear that as a health professional because, you know, we know some things are more likely to happen. Wrong things or bad things are more likely to happen when teenagers do use. But if that ever changes, I hope we can talk about it. Something short and sweet like that can make a difference and might further delay the initiation of use. And then remember too that, you know, like adults, teenagers use substances for positive reasons. It's important to acknowledge this because it's the truth and because you're kind of empathizing as a fellow human being why someone might engage in a behavior that poses risks because there's pros and cons to substance use. So what are the pros, even if they're short-term pros? Well, teenagers' brains are specially designed to be attracted to new experiences, to take risks. But like adults, they also want to escape from problems, even if it's a temporary escape, and even if that way of escape produces more problems, still in the moment it may feel like they're escaping from their problems. Wanting to perform better in athletics or at school, you know, abusing Adderall, our peers influence us, and maybe it just feels good. So like everyone, adolescents use substances for positive reasons. It's important to keep that in mind. So how do we address adolescent substance use? Whether it's in a virtual environment or not, how do we do it? Well, we screen and we intervene. It's as simple as that. And that's how we address a lot of health issues. We screen for things and then we intervene when there's a positive result. Specifically, however, when we screen for adolescent substance use, we should do it universally, which means we screen everyone. You know, the definition of screening is we are going to investigate a health behavior based on prevalent statistics alone. And that's different than waiting to until you're suspicious, clinically suspicious, that certain patients may be using, other patients may not. You're making personal decisions and judgments who you're going to ask. Well, we don't do that when we're going to address substance use appropriately. We screen everyone, and that's because on those slides earlier, we saw how prevalent it is, that justifies screening everyone. The other part of it is routinely, meaning, again, we just don't do this when we feel like it. We should do it on a routine basis. Once a year is generally accepted. As you know, however, we're probably not going to see most of our adolescent patients once a year. So when they come in for a sore throat, or they're presenting to you virtually with a sore throat, or they're following up with something, that may be the only time you see them for 2 years. So you should screen during that visit too. If you reserve this just for well visits, when you do a lot of screening, well, you may miss a lot of adolescents who don't come in for well visits, but they present for a telehealth visit for something else, and that's a valuable opportunity to screen for this. However, I do empathize with providers who are given 15 minutes perhaps to do a visit, and they feel like 15 minutes is not enough time to address what they're supposed to address, besides trying to push in a substance use screening form. But that's the reality we face in primary care, at least. And then we should use a validated tool. It may seem natural for you to just ask your patient. So I'm curious, do you drink alcohol? Do you use cannabis? Do you use any other drugs? Sound like innocent enough questions, direct, forward, but human beings are complicated when it comes to disclosing behaviors that may imply judgment or stigma. And there's some very smart people who are experts in psychometrics who design screening tools, and they test questions against a gold standard, the gold standard being a half-hour interview with a trained psychiatrist, and they test these questions to see how well they correlate with the gold standard. So they put a lot of work into these screening tools, and the tool we're going to look at today has a sensitivity and specificity of in the mid-80s. So they work pretty well. They're validated. So why not have the tool do the work for you, read the questions as they're written, and we're more likely to get honest answers from our adolescents. So we screen universally, we do it routinely, and we use a validated tool. And then we intervene. And how do you intervene with substance use? It's a discussion. That's all it is. It's not a referral, like an automatic referral. What I mean is a referral to treatment. If during your process you do, in a clinic setting, have a behavioral health specialist come in to do this, that's great. In a virtual setting, probably can't do that. If you try to schedule a visit with someone else, they may not follow up and do that. So you should intervene with a discussion immediately after the screening tool. And what is the discussion? As you probably know, it should be something based on motivational interviewing, which is the only evidence-based model we have that's shown to enhance behavior change. So that doesn't mean you have to go away to a 4-day seminar and be a certified MI trainer. You're not a psychologist, or maybe you are in the same, but if you're not, that's okay. You probably only have 3 to 5 minutes to have this kind of conversation with an adolescent. You can still be effective using a model we're going to talk about without having to be an expert in this. And then I would also add, let's use a harm reduction approach, which basically is be pragmatic as well as compassionate in regards to how we can help patients. We'll talk about that a little bit too. When we screen, what are we looking for? We're going to put our patients or our clients or whoever in these 3 categories, essentially. Low risk, risky disorder. Low risk for adolescents means they don't use it all, or they use like here and there occasionally, once or twice a year. They don't use on a routine basis. That's low risk. Risky, however, means they use and they're not experiencing current consequences, but they're using on a regular basis, and that poses risks to their health. This is where we can do the most good to prevent consequences in the future. Disorder is not only is a teenager using, but they are experiencing continued negative consequences despite their use, and they continue to use anyway. And it's important to identify those folks. That doesn't mean you have to make a formal diagnosis. That's not important. That can be done later by a trained professional if that patient's ready to get treatment. But if they score high enough on the screening tool, odds are they are experiencing a disorder. So these are what we're looking for here in screening. And, unlike adults who can drink a certain number of drinks before they're considered risky, if someone, like if a teenager uses, 2 or 3 drinks most weekends, well, that's still putting them at risk, unlike an adult. That's because, again, their brain is more sensitive to alcohol than adult, and their brain's also designed to do risks and make poor decisions, so that even after a couple drinks, they may do something that can result in tragic consequences. And again, statistically, the earlier they begin using, even if they don't use that much, the younger they are, the chances of addiction later in life go up. So in telehealth settings, if we're using electronic means, this is a study I found, and it just asked teenagers, how comfortable would you be answering questions about health behaviors, including substance use? How honest would you feel about it? Depending on if you were given a paper form, if these questions were delivered through a provider interview, or if they were given through like a tablet. Honesty and how comfortable you are. And as you can see, pretty small numbers of teenagers disagreed that they would feel comfortable or honest about being asked about things like substance use. And the smallest portions were with electronic means. So I think this can be extrapolated that in a virtual visit, if we're doing an interview, most teenagers are going to be comfortable with this. Most teenagers will answer honestly. If they fill out these screening questions before the visit as part of like a screening app or patient portal, again, they're even more likely to be comfortable and honest. So I think we can screen in different ways with confidence here. So again, you may have had lots of experience. So this pandemic's been going on almost for a year now, and you've probably been having telehealth visits with teenagers. So you probably have developed some tips and strategies that make it seem to go better. I'm just going to share what I've learned with you. And one of them is don't worry too much about having, your medical degree or some kind of office setting in the background. In fact, teenagers through social media are pretty familiar with informal settings in the background. So if it's your kitchen, like me, or your bedroom, and you're comfortable with that, leave it that way. It makes the setting a little more comfortable. If you want to use a virtual background, which is available in Zoom and WebEx and things, feel free to do that. But it's also an opportunity to engage the adolescents. Say, hey, what do you think of this, the Golden Gate background? Or here I'm on the beach. What do you think about that? Which one do you like? Let them choose maybe your virtual background. So a way to engage them. Make sure, you can usually see yourself when you're during a telehealth visit. Just make sure that you're not far away or off to one side. Facial expressions, if we want to communicate and engage with an adolescent, are important. Now, your adolescent patient does not have to meet up to those expectations. In fact, a lot of times they may be really off-center, not looking at the screen, maybe have a hoodie over them, maybe even will have you on, but will be totally off-screen. That's okay. If that's what makes them feel more comfortable to talk to you and disclose what's going on, that's fine. But your responsibility as a professional and to engage the patient should be in the field of view and zoomed in close enough so they can tell what your facial expressions are doing. And then it's helpful to look at the screen because it looks like you're looking at them as much as you can. If you're taking notes, probably have to. If you're taking notes into the computer, it may be okay because you're still looking at the screen. If you're taking notes to the side, try to minimize that, but also just be frank about it and say, just so you know, during our visit today, you may see me looking to the side, and that's because, or typing, and that's because I want to remember what we talk about. Sometimes I don't remember everything, so I take notes. Is that okay with you? Say something like that. Privacy is important, of course. Teenagers are a lot less likely to be honest about their substance use if someone can overhear them, especially if it's an adult, especially if it's their parent. Again, you probably have tips on how to ensure privacy as best you can. So some of them here as well, just ask them, before we start the visit today, I just want to make sure, are you comfortable speaking with me openly? Is there anyone who can hear you? If you use yes or no type questions, that way they can still answer without disclosing something to someone who can hear them. If they're at a desktop computer and they don't feel like they're in a private setting, you can ask them, how about, do you want to log out and reconnect on your phone? And maybe you can take the phone outside, or it's just easier to go to a more private place. Using earbuds might be more helpful. At least, you know, your parents can't hear me talk with you if you're wearing headphones. So these are some strategies to help encourage privacy. And then, you know, engaging the patient in general. Like I said earlier, when you ask the patient to choose maybe a virtual background, non-professional connections are just a great way to engage in adolescence. So maybe you have a pet running around in your space. You know, pull them up and introduce them to the patient briefly. Hey, this is my dog, Zoe, and the German Shepherd or whatever. Do you have any pets? Or, God, I had a great lunch today. I had pizza. What did you have? You know, or I know from our last visit that you're a big baseball fan. You know, how did your team do? Whatever it is, it's nice to start out the visit with a connection that doesn't have to be about the medical visit or the mental health visit. And again, like I said before, if you're taking notes, just be frank about it, why you're doing it and how you're going to do it. And if there are interruptions, like the patient's dog is barking, their older sibling comes into the room and they get into an argument and leave, or whatever happens, you can use that as an opportunity to connect. Like, oh, was that your brother? You know, how do you get along with him? Or is that your dog? How old's your dog? I have a dog like that. You know, don't look at interruptions as solely, oh, it's interfering with my time and I'm on a schedule and I'm all screwed up now. Look at them as little breaks to reconnect with your adolescent. Okay, if you can't get the patient in a private setting, try to stick to yes or no questions, like I mentioned earlier, because that is a way to still give you the information you need most of the time, but in a way where the patient's not disclosing what's going on to someone who might hear them. You know, I don't know how reimbursement works if you have to stick to a phone or a text function, but if you can keep the patient online virtually through a screen, but communicate just through the chat functions or text, that's another great way to make sure things are private if they're not in a private space. If you really have to, give them option to reschedule. You know, would this work better for you if we did this again tomorrow or the next day at this certain time where you could be in a place that's more private? Or maybe after the visit, you ask questions through, if they're willing to share their cell phone number with you, you can ask those questions through text that you weren't able to get to during the actual visit. When we screen for substance use, there's two ways to do it. We either do it during the visit, during the interview, which I'm going to talk about, but some of your adolescent patients, probably not many, but some adolescent patients do have patient portals. So if they fill out paperwork through that portal before the visit, there's advantages to that. It saves time. They can probably answer those questions wherever they want, you know, on their phone or computer. There's cons, though, that I know with patient portals, sometimes it gets lost in some tab in your EHR and you forget to go to that and look at those answers because it was done during the visit. Or maybe they didn't understand some of the screening questions beforehand, and because it wasn't live or synchronous, you weren't able to clarify questions. So there's pros and cons to that. During the visit, I think is ideal because not only are we screening for substance use in person, when we do it in person, it's an opportunity to build rapport. We're not just screening for substance use, we're building rapport with the patient. If they have questions about a screening tool, we can explain things in real time and clarify things immediately. So I do prefer doing this live during the visit, but a patient portal has advantages too. When we screen for this, it can be done as part of any visit. Like I mentioned earlier, it does not have to be just a well visit. You have more time during a well health visit or whatever it's called, maybe, but it can be done during any kind of visit. It can be done at the beginning, middle, or end. It doesn't matter when you want to address substance use, but you should do it during the visit at some point. We should raise the subject and ask permission. Hey, now that we're done talking about your sore throat, I want to ask you if it's okay if we go over like 6 or 7 questions about substance use. That's because we are supposed to ask these questions with all our adolescent patients. Is it okay if we do that? So raising the subject, explaining why you're doing it, we do this with everyone, not just you. And asking permission is not just a formality. It actually sends a message that I want to embark on a conversation together rather than I'm going to be telling you what I think you should do. So asking permission is, you can ask permission for everything. It's always a positive thing to do when we're having discussions with adolescents. Again, use a validated tool. And when we do this live with a patient, just get the data, clarify questions, don't comment. You might be tempted, if a patient discloses to you that they're drinking 10 to 15 beers a week, that may startle you, but withhold any judgment or comment until we do a brief intervention. That's when we address that. So I'm going to talk about the craft. It's the best tool, I think, right now to use. There's another one called the S2BI. Good tool also. The craft has more support as far as it's always being updated with new languages or new terms to better describe adolescent use. It's good for diverse populations. Again, it can be done, handed to the patient electronically in paper through an interview. And it's available again on our website, a lot of websites. When I mention raising the subject when it's time to screen for substance use, this is an example of how I could say that again. One of the things we do with all our patients is ask a few questions. We know that a fair number of teens use substances. We know it can impact their health. So this is why we ask about it. Is that okay with you? So we're introducing the subject, asking permission. This is the craft. And I have just on a PowerPoint here, but this is a great opportunity to share your screen. You don't have to, the patient can see your face and they're listening to you ask these questions. But a way to engage your patient is just say, I'm going to share my screen here so you can see this form that I see and we can look at it together. Do you see this? Let's look at the first question here. It looks like, in the past 12 months, so think about the past 12. So you're going through this together rather than, you have a clipboard, I ask you questions, I write down the answers. Look at it as a joint exercise here by sharing your screen. Probably the best pro or positive to a virtual telehealth visit is the screen sharing function. Because it is a tool to make the adolescent patient feel that you guys are a team doing this together rather than being separate. So you can go through these questions together. These are the consequence questions. And again, if your teenage patient doesn't quite understand what the question is asking, you can clarify that, but try to ask the questions relatively verbatim, because again, these questions have had a lot of work to be phrased just right to ensure the greatest chance that an adolescent will be truthful with you. Based on the results of your questions, this is how what you're supposed to do. If someone answers no, they don't use it all. Few words of positive reinforcement. Brief education for those folks who use very rarely, but everyone else should get a brief intervention. And tips on doing a brief intervention, which is just another word for a discussion. Same thing as screening, really. Just reconfirm that there's privacy, try to maintain eye contact, and it's another opportunity to share the screen. Because in this case, besides the screening tool, we can share what I call the reference sheet. And I'm going to share the link so you can look at this as well. So in the chat here, if this works correctly, to all attendees, I'm going to put the link here. Feel free to click on that. And then I'm going to share my screen right now so we can look at this together. Let's see, share application, and this will be Firefox. So hopefully right now you see this big yellow sheet. This is available on the Esprit Oregon website. And it's a great opportunity to, again, instead of having a didactic lecture from a clinician, why don't we look at the information together as part of this discussion? So when you share the risks of substance use with adolescents, this sheet shows you what the risks are. You can kind of read this together. When teenagers have drinks at parties, or when they used to drink at parties, a lot of them use this ubiquitous red party cup, and they don't really know probably how much alcohol they're drinking because it depends on the type of alcohol. This is a nice diagram to use. When you ask your patient how ready they are to change something about their use, there's a visual scale here. So this front part of the sheet is really helpful to share with your patient. Now, for you, you don't want to share the back of this because these are your crib notes. And this is another advantage of telehealth. You know, the biggest struggle we have as trainers in Esprit or addressing substance use is the fidelity to the brief intervention, because it's a new skill for a lot of providers. It takes role play practice. There's probably a lot of poor quality brief interventions going on. Well, the advantage of a telehealth visit is if you pull this up on your screen for you to see, your patient just sees you looking at the screen. It looks like you're looking at them, which you can through a little window as well. But this is a great way to remind you what, in this case, are the 4 steps of the brief intervention with some text prompts on that guide the conversation. So how to raise a subject, how to explain if there's an association between the medical complaint and their use. You can share what the risks are. And I'm going through this quickly because, just to respect our time. Ask them about their perceived pros and cons of their use, summarize that, and then ask them, where do you want to go from here in terms of your use? What's your goal? Asking them again, how ready are they to achieve that goal? And why do they think they're that ready instead of being less ready? Asking them what plan they might have to reach that goal. So again, the advantage of a telehealth visit is you can pull this up, you can look at it, help you guide the conversation, and you can keep the patient engaged while you're doing this. 1-800 number for Oregon for treatment places, you can change that. How to interpret the craft, reimbursement information. So the back again is kind of your crib notes as the provider. The front is something you can share with the patient. So again, this is really valuable, I think, to take advantage of when you're doing a telehealth visit. So I'm going to go back to my slides here. I think screen 2. And do people see my slides again now? Hopefully. Someone let me know. So the 4 steps of the brief intervention model that I support and promote are on that reference sheet. And if you want, on that website, you can go through each step of that model in more detail. But again, we're raising a subject. I would be transparent about your role. I would say something like, now that we're done screening and filling out this form, is it okay if we talk a little bit about your substance use? And just so you know, I'm not going to ask or advise you to stop or change in a way that you don't want to. Instead, my role is to focus on what you want to do. What are your goals and visions about your use? How does that sound to you? So just being transparent about your role can put your patient at ease if they might be worried that you're going to judge them or lecture them. The next step is to share information about the risks. It's perfectly fine to do that. That's not being judgmental. You're just conveying the information we know in the world of health research. Ask your patient what they think of it. Stay away, I think, from giving advice because it risks further stigma. Adolescents probably already know they're not supposed to be using substances. So giving advice isn't going to help change anything. It's not evidence-based. The third step is asking them, I'm curious, what do you like about your use? And I'm curious what you do not like about your use. So people start to make changes when they analyze the pros and cons of a behavior. So you should ask them about both and then summarize what you hear. On one hand, you're telling me that when you're high on cannabis, it feels relaxing, you giggle, sometimes you do it with your friends online, but on the other hand, you realize you're falling behind in school, you want to play on the soccer team when the pandemic ends, and you know you'll get kicked off if they find out. So weighing those two things, how likely are you to change your use? Another ways to say this are, where do you want to go from here? What would you like to do? If you can get a concrete defined goal from your patient, they're more likely to achieve it. It doesn't have to be cutting back their use or abstaining. It can also be just using in safer situations. Like I mentioned, it could, when we take a harm reduction approach, it could be limiting their use or abstaining, but it can be other things too. Promising or planning not to do it when they know they're going to have sex or get in a car, avoid getting in a car with someone who's intoxicated. Or maybe they're not ready right now to change their use at all, but they're ready to continue to see you or just check in 4 to 6 weeks. And that's a big accomplishment, actually. You should pat yourself on the back as a clinician if an adolescent who's using agrees to do that. And then gauge their readiness to do that plan using the readiness ruler. Ask them to pick a number from 0 to 10, how ready they are, and then ask why not a lower number. That gets the patient to verbalize motivation to change, and that act of verbalizing it is what we know enhances the motivation to do it. And then if they sound ready, the last step is, well, what would that plan look like for you? You know, it sounds like you don't want to use cannabis alone anymore. How could you make sure that happened? You know, what would you put into place? People are more likely to change the behavior when they come up with their own plan on how to do it. These are the 4 steps. This is what it's on the reference sheet. And then if you do have follow-up, you know, it's a collaborative kind of checking in. How did your plan go? Is there any other new goal or plan you come up with? Do you want to change your plan or come up with a whole new goal? Again, it's checking in. And remember, the ultimate message here is we do defer to their decision. There is no evidence behind the effectiveness of persuading your adolescent patient to do something you think they should do. In fact, the more responsibility and autonomy and respect we give our patients, the more room they have to step up and forge their own pathway to change. And that is a good slide to end on because we're at 10:55 my time or 1:55 East Coast time. And I will leave it there. Thank you for listening, and feel free through the chat or otherwise to have any questions or comments. Glad to hear people are finding this information helpful.
Okay,
yes,
yeah, there were a couple that came in also, if you wouldn't mind, that Marla and I had gotten. One was, one of the participants was curious as to what your suggestion would be to address adolescents who state they're utilizing marijuana as medicine with the new improvements in medical marijuana.
Right. So I would be honest about, well, how do you feel using cannabis helps you? What do you like about it? So going back to that step in the brief intervention and acknowledging. So I'm hearing you say that when you use marijuana, it feels like your anxiety goes down, for example, right? So acknowledge that. But again, follow that up with, is there anything that worries you about your cannabis use? And they may not have anything that worries them, but be honest. Well, I can tell you as a health professional that even though marijuana can maybe help people feel less anxious, we know that heavy use of cannabis can also increase anxiety or even depression. So I want to be honest with you about the risks of cannabis use as an adolescent, in addition to what you like about it. Another thing we know is that teenagers' brains are developing in a way that adults aren't, and that means their brains are extra sensitive to substance use. So even though it may help you with something, like a health issue, it also may be stunting your cognitive function. So just be honest about what the risks are to cannabis use, and put away any expectation or goal you might have to convince or persuade your patient that they should stop using or look at it in a different way. Try to get them to make an analysis, to explore things. That's where change comes from. And that can be hard because an adult, and we care about our adolescent patients, it may be difficult to hear from them that they're going to continue using a substance that we know as a health professional poses risks. But that's how behavior change works. We have to kind of roll with that and give them space and autonomy to determine on their own what they want to do. You can act as a resource, right? You can do a high fidelity brief intervention. You can share information, but you can't convince them to change. Hope that helps.
All right. Another one that we had was, what are your thoughts about virtual group treatment?
What was that question again?
What were your thoughts about virtual group treatment?
Oh, okay. Yeah, treatment is a specialty that's kind of outside the parameters of this presentation, because when it comes to treatment, our job in primary care settings or emergency room settings is to identify adolescents who might benefit from treatment, and then it's up to them if they are ready to access treatment. But when it comes to how effective treatment is, whether it's a peer group, a one-on-one counselor, or the family's involved, and even more into the detail, is virtually, is that more effective? That's outside my expertise because I'm not a treatment professional. What we do when we address substance use mostly is try to identify those adolescents who might be or are likely to experiencing a substance use disorder and would benefit from treatment. So treatment is a whole nother specialty that I don't get into here.
Okay, and someone said they were interested to know your thoughts on youth in treatment in a recreationally legalized marijuana state. School mandates treatment if caught in school. I would assume meaning using marijuana. If they were caught in school to stay enrolled, but perception of risk is down to legal adult use.
Now, there's a lot in that question. It sounds like a policy question, like, do I agree with that policy of mandated treatment for in schools when teenagers get caught using? That's kind of outside my expertise too, although I would say when someone is forced to do something they're not interested in, I doubt it's likely to be effective. However, again, that would be a question for a treatment professional.
Yeah. Okay. Well, just to be courteous of your time and everybody else's time, we are going to close the Q&A period now, but if anybody who is on the webinar has questions, feel free to email us at info@ireta, or you can also email Jim. He has his email up on the screen here. There were quite a few comments too about the slides and the reference worksheet, that the yellow worksheet that Jim had up during the presentation. We are going to link the slides with the recording of today's presentation, and we'll also have a link to that reference worksheet. So you'll be able to find all of that on our website. I want to thank everybody for their questions, and I want to especially thank Jim for such a great webinar. We do want to remind everybody about our evaluation and CEU process. You will receive several follow-up emails from us. The first will include a link to the evaluation, and the second will include step-by-step instructions on how to obtain CEUs. Please note again that it can take up to 48 hours for your CEUs to become available because we do cross-check attendance records. We would especially like to request that you can fill out the evaluation. It should take no more than 2 minutes of your time. We want to thank everybody again today for your participation. And if you have any questions, please reach out today. And that's going to be all today. We're going to conclude the webinar. Thanks again so much, Jim, and thanks everybody. Have a great day.